Distinguished chairperson, distinguished colleagues, first of all, I would like to thank the organized committee for this invitation. I'm going to proceed the presentation in Greek. Θα ήθελα να ευχαριστήσω την Οργανωτική Επιτροπή για αυτή την τιμητική πρόσκληση και τον Πρόεδρο καθώς και τον συνομιλητή μου που μου έδωσαν τη δυνατότητα να μιλήσω πρώτος λόγω αλληλημένων υποχρεώσεων που έχω. Αυτό είναι το slide δήλωση συμφερόντων μου. Γνωρίζουμε λοιπόν ότι η κολπική μαρμαργή ουσιαστικά είναι η πιο συχνή αριθμία. Περίπου 45 εκατομμύρια άνθρωποι παγκοσμίως πάσχουν από κολπική μαρμαργή και περιμένουμε στα επόμενα χρόνια η επίπτωση της κολπικής μαρμαργής να αυξηθεί και αυτό συμβαίνει κυρίως για δύο λόγους. Από τη μια πλευρά, ο μέσος όρος επιβίωσης παγκοσμίως αυξάνεται.
Could I ask you if you could do your presentation in English, please?
Well, actually, nobody told me that I have to present my presentation in English. However, I will try. We know that atrial fibrillation is practically the most common arrhythmia. More than 45 million patients present atrial fibrillation, and we are expecting over the next years the incidence of atrial fibrillation to increase, and this will occur mainly because of two reasons. The lifetime expectancy worldwide is increasing, and we know that the elders and very elders are the patients that more often practically present atrial fibrillation. And the second cause is that the fact that the incidence of all these risk factors that predispose for the development of atrial fibrillation will increase with a subsequent increase in the incidence of atrial fibrillation. Now we take a look in the cardiovascular continuum. We'll see that the different risk factors throughout several mechanisms predispose for the development not only for coronary kidney disease, but also for coronary artery disease, myocardial infarction, and heart failure. Conditions, however, that increase the risk for the development of atrial fibrillation, and thus very often atrial fibrillation and chronic kidney disease coexist. We know that the patient, regarding patients with atrial fibrillation, approximately 50 to 20% of them present also chronic kidney disease. And regarding patients with chronic kidney disease, approximately 50% of these patients presents also atrial fibrillation. So frequently we have to deal with a patient with atrial fibrillation and chronic kidney disease, and we know that they have several peculiarities, these patients, mainly because of the chronic kidney disease. First of all, we know that chronic kidney disease increase the risk from thromboembolic events, since increased the prothrombotic state due to the inflammation, due to the endothelial dysfunction, but also due to platelet dysfunction. But on the other hand, the same mechanism increase the risk for hemorrhage, especially the platelet dysfunction, since we can't have the formation of the white thrombus. That's why impaired renal function is a key factor for the Hasbled score in patients with atrial fibrillation. So in these patients with atrial fibrillation and chronic kidney disease, we know that these are patients with increased thromboembolic risk, but also with increased hemorrhagic risk. And in these patients, we have to add also an oral anticoagulant, something that may aggravate the hemorrhagic risk. Now, this is the case. This is a male patient of 65 years who came to our outpatient clinic for assessment. This patient was hypertensive, hyperlipidemic, diabetic, and with chronic kidney disease. The patient was asymptomatic, not only at rest, but also during exercise. He was overweight, and he had an office blood pressure of 132 to 75 millimeters of mercury. Of course, we know from all the guidelines that we have to perform also out-of-office blood pressure measurements, since 33% of these patients may have white hot hypertension, and 70% of these patients may have also mask hypertension, and especially in patients with diabetes, mask hypertension occurs very often, and that's why we have to perform out-of-office also blood pressure measurements. Regarding the laboratory exam, we didn't have anything special. We can see the creatinine, which is slightly high. However, in all patients, we have to calculate the GFR in order to know the proper function of the kidney. Now, this patient was under treatment with 10 tablets, as you can see, of mesartan 10 milligrams twice daily, amlodipine 5 milligrams twice daily, atorvastatin 40 milligrams once daily, metoprolol 100 milligrams 1/4 3 times daily, and metformin 2 grams daily. We performed an ambulatory blood pressure measurement in this patient. As you can see, blood pressure levels were the proposed limits. However, we had several measurements with increased heart rate. In addition, the echocardiography, as you can notice, we had the left atrial dilatation. That's why we proposed to the patient to undergo 24 hours Holter monitoring. As you can see, this patient had severe periods of atrial fibrillation. This patient had paroxysmal atrial fibrillation. Now it's imperative to search for atrial fibrillation because not all patients have symptoms. 25% of these patients present silent atrial fibrillation with that unfortunately has the same risk for thromboembolic events with the overt atrial fibrillation. And of course, in this case, we have to calculate the CHA2DS score. As you can see, this patient, because he's hypertensive, diabetic, and 65 years old, has a CHA2DS score of 3, 5.9% of risk for a thromboembolic event every year. In 10 years, this risk is 59%, so we have to add also an oral anticoagulant. As I told you before, we have to search for atrial fibrillation in patients with increased risk or suspicion of atrial fibrillation. If a patient is hypertensive, we have several devices with special algorithms that can detect arrhythmia. And in these patients, when we find a period of high arrhythmic burden, we have to perform a 24 hours Holter monitoring because in order to diagnose atrial fibrillation, we have to record the atrial fibrillation. In addition, we know that the higher the CHA2DS score of the patient, the higher the risk of the patient for the development of atrial fibrillation. And taking all this together, we had a patient of 65 years old with left atrial fibrillation with increased CHA2DS score, with palpitations. This is the ideal patient to perform the 24 hours Holter monitoring in order to assess if this patient has atrial fibrillation. Now, the first thing to do is to simplify the dose regimen in order to improve adherence to treatment. So we practically use fixed dose combination in order to decrease the number of tablets from 10 to 5 tablets every day. And of course, we have to add also a direct oral anticoagulant. We know that the higher the number of the pills, the lower the adherence to treatment because it's more complicated than the therapeutic regimen, and it's more often, of course, that the patient may skip one dose of the drug. We use direct oral anticoagulants because we know that these drugs, these medications, are at least as effective or more effective than the VKA's antagonists, with depending the dose, with less hemorrhagic events. But we also know that VK antagonists increase the vascular calcification, something that may aggravate also the renal function, especially in patients with chronic kidney disease. And in addition, we know that in diabetic patients, some direct oral anticoagulants practically may help to reduce the incidence of diabetes complication in these patients. That's why we have decided to use a direct oral anticoagulant. Now, these are the new guidelines released 50 days before. According also these guidelines, we have to have an holistic approach to a patient with atrial fibrillation. So we have to, first of all, to control all the different risk factors. We have to insist to lifestyle changes. If the patient is highly suspected for obstructive sleep apnea, we have to perform a test in order to see if this patient had obstructive sleep apnea. And the fact that this patient had also chronic kidney disease is a fact that leads us to decrease the dose regimen. As you can see, in the majority of the DOACs, a GFR below 50 result to a decreased dose of DOACs. And of course, regarding apixaban, we have another approach. If the patient is above 80, below 60 kilograms, and have a creatinine levels above 1.5 milligrams per DL, it has 2 of 3 parameters. He has to take the lowest dose of apixaban. Now, in this patient, other than adding the oral anticoagulant, we have to see if we have to continue to rate or rhythm control. Of course, our patient had paroxysmal atrial fibrillation. He was already on sinus rhythm. However, in order to give him medications to increase the period of sinus rhythm, we have first to see if this patient has ischemia, if he has any structural abnormalities in his heart, in order to see which drug we have to continue. And of course, we have always the case of catheter ablation with a very strong evidence, class 1, in order to proceed to rhythm control in this patient. However, we have to keep in mind that we have to have an holistic approach. We don't have to focus only on atrial fibrillation. We know right now that the use of SGLT2 not only decrease the rate of kidney disease progression and decrease the incidence of acute kidney injury, but also in these patients, we may have an improvement in their prognosis since they decrease cardiovascular morbidity and mortality. And that's why in the very recent KDIGO 2024 guidelines, as you can see, in patients with impaired renal function, if they have diabetes, we have class 1A to administer SGLT2. If they don't have diabetes and have an albumin creatinine ratio above 200, we have a strong evidence 1A to administer SGLT2. And in case that the albumin creatinine ratio is below 200, we have an evidence 2B in order to administer SGLT2 in this patient. So we have to have an holistic approach in patients with atrial fibrillation and chronic kidney disease. We have not only to focus on atrial fibrillation, but also kidney disease. We have not only to treat atrial fibrillation, but we have to treat also the other risk factors. And of course, we have to treat chronic kidney disease in order to slow the progression of the chronic kidney disease. Thank you very much.